We're going live. We may be live. So if someone out there could let us know. So yes, I think we are live on Facebook. And I will also record this session on this. There we go. All right, perfect. So good morning, good afternoon, good evening to everyone who's watching, and welcome to our POHER Scholars session for today. I am super excited about our speaker. So I am Dr. Akwi Asambang. I am an interventional gastroenterologist. I am also the co-founder of the Pan-African Organization for Health Education and Research. I'm very excited about today's meeting, and I will introduce our speaker. So our speaker is Dr. Breton Roussel. And so I know him because we work together. He is an absolutely stellar gastroenterology fellow at Brown University. So Brett was actually the chief internal medicine, the resident at Brown, and then he joined, he joined or remained at Brown for his fellowship. And I don't know, Brett, if you remember, I had actually interviewed you.
I remember it in detail. I do.
So I had actually interviewed him for the fellowship. I was one of the faculty who interviewed him, and it was just a fantastic interview. So I'm super excited about today's meeting. So as a chief resident, hopefully you can actually, I know that's not the focus of our talk today, but maybe you could kind of talk a little bit about what it means to be a chief resident, because that's really a huge deal. Maybe you could also explain, how many residents you were in charge of, and some of the tasks that you had to handle. One thing I can tell you for sure right now is, as a GI fellow, he is the first person who anyone would call for an emergency before they even call us, the senior consultants. So they would call him, and you have to be fast acting. You have to know what to do. You can't just laze around, and Brett does exactly that. When he gets the call, he knows what needs to be done, and then he'll give us a call, with his thoughts, his plan. And I'm usually impressed. He's sometimes already gone and, reviewed images with radiology. He does teaching with medical students and residents. And sometimes I'm like, why am I here? So anyway, about today's talk, he is going to be talking about how to present at a journal club. He's presented multiple times. He's done this a gazillion times. So he's going to talk to us about that. He'll talk about how to select an article for journal club. And once again, to the scholars, just remember, this is your session. And so, write down your questions. Feel free to ask him any questions. And I want to say on behalf of POHER, I am absolutely grateful for you taking the time out to be here with us today. It's a Saturday at 8 o'clock in the morning. And so this is a really big deal. So I just can't thank you enough. And so on behalf of the Pan-African Organization for Health Education and Research, thank you so much, Dr. Roussel. Truly appreciate your time and effort and energy. I'm looking forward to learning from you as well. And on that note, I'm going to hand it over to you. You should be able to share your slides. And for those who are tuned in, you can obviously, just raise your hand, have a conversation with him. All right, I'm going to turn off my mic, turn off my video, and it is all over to you, Dr. Roussel. Thank you so much.
Wonderful. Thanks, Dr. Asambang. 8 o'clock, I was explaining to Anya, is not so early when you're a GI fellow and you're going into the hospital bright and early. So I'm very happy to be here today, and I appreciate the opportunity to speak with all of you. And I really mean it. I want this to be a conversation. So if any of you have any questions, please feel free to interrupt me. You can keep, your cameras on. If we want to talk some more about any subject that's either related to this or anything else, please feel free to kind of interrupt. And then Dr. Asambang, back at you. When things get busy and scary at the hospital, it's wonderful to have such great leadership and teaching from you as an attending. So it's always a team effort, and I want to say I appreciate it. So we're going to be talking about Journal Club today. Journal Club is something that is implicit to medical education in medical school. You do it again in training, and then even in your career as an attending, Journal Club will be an important part of your learning and incorporating new data into your clinical practice. So I think this is, it's an important topic. And I think as a trainee, I think early on too, I remember getting assigned Journal Club, and you're busy, you have clinical obligations, you may be doing research, and then there's a presentation you have to give. But I think looking back on it and having done it now many times, I realize how valuable it is in my own learning and then in fostering a community of learning with people that you work with. So can I get a show of hands, and you can use the little Zoom raise your hand of people who have participated in Journal Club before? So have people done this before? And you can even in the text box or raise your hand, let's say if you've not done Journal Club before. All right. Looks like people have participated. So let's see if we can move on. There we go. So Journal Club, why do we do Journal Club? This is a picture of one of our internal medicine groups at Brown, rotating through Miriam Hospital, talking about some patient cases, going to see patients in the morning, and then discussing their plan for the day. And I want to make the argument that Journal Club is important because we do Journal Club every day, dozens of times, be it in our own minds where we think about a medical decision and we apply current evidence, or even in rounds where you may bring up a paper and briefly discuss it. Journal Club is exercising evidence-based medicine in more of a formal format. And I think it's important for us to do that because we do it every day and it's practicing. You know, if you play soccer, getting onto the pitch and practicing before you have a game, I think Journal Club hones a lot of those skills that we use in everyday clinical practice. And it's better for us as learners, as teachers, as physicians, but also too for our patients. Now, it wouldn't be a Journal Club presentation without talking about evidence on Journal Club. There's been some research on this, about 100 papers looking at how to do Journal Club and why it's important. And I'm not going to go into these articles today in detail, but I wanted to just show you that this is something that's been studied. And I think there are many ways to do Journal Club. There are some ways that may be better than others based on data. So why is this important? I tried to boil down some things that I really take away from Journal Club. And getting back to rounds and going to that internal medicine group that was rounding on the wards at Miriam Hospital, you know, it can answer a specific question. If you have a patient and a decision you need to make, and perhaps as a group you're undecided which clinical tree you want to go down or how you want to treat a patient, going back and using Journal Club as a format to review literature to help make a decision, I think could be very valuable. It helps us develop our analytical skills. It helps us to think critically. It helps us to understand what data is, good data, bad data, and is it applicable to a specific clinical situation. Two is kind of an exercise in statistics. It's really neat in medicine that we have people that we work with that have varying degrees of research experience and stats experience. I've worked with people who had PhDs in statistics. I do not. But it's a lot of fun to work with those people. And I think when you go through Journal Club, they can be good mentors and teach you some things that they've learned, but also too, as a physician, through my own learning, I've learned about some statistical methods that may be new to somebody else that I could teach them. And going through the exercise of breaking down a paper and understanding the statistics too is really good at kind of self-teaching and learning things that you may not know before. And then, you know, I talked about this before, we work in a community. It's a community of learning. Medicine is never an isolated silo. We work with different specialties. We work with different healthcare professionals, nurses, physical therapists, scientists, other physicians. And I think it's really important to have a diverse Journal Club group to go through these articles and build some camaraderie from an academic lens. Okay. And then finally, you know, what's neat about Journal Club are the ideas that always come up at the end. You know, we will talk a little bit about how to wrap up a Journal Club and to summarize and bring meaning to it. But one thing that's really interesting is the ones that I've been to, we always talk about, hey, what would you do next? You know, this was a really interesting pilot study. How would you design the randomized control trial to address that specific question? And I think Journal Club is very effective at sparking inquiry. All right, so I could wax poetically about Journal Club for another 10 minutes, but we'll get into our learning objectives for today. So first, we're going to talk about the rules of Journal Club, things that the evidence has suggested makes Journal Club successful. Then we're going to talk about different methods for choosing an article, which can sometimes feel daunting. So we'll break that down a little bit. We're going to talk about the different components of a Journal Club presentation, things that have found important for incorporating and things that we at Brown have really encouraged our trainees to incorporate in their presentations. And then we'll talk about experiences with Journal Club, and I want to open it up some more to you all. So this is from one of the papers I had featured before. This was published in 2018. It was a review. It went through and analyzed different Journal Club articles on Journal Club to try to pick out things that are important for running a Journal Club. So this isn't so much about the format of Journal Club as it is about running Journal Club. So if you are assigned an article, I think this applies. I think if you find yourself in a leadership position in the future and you're organizing journal club, I think these apply as well. So I think the first and foremost, it's common sense to know that you want clearly defined goals and objectives. And the reason you want that is it needs to be consistent from journal club to journal club. So if you, as a trainee or at an institution, and you're asked to do journal club, really look back and see what your department values, how they like these journal articles presented. And I think that consistency really allows for continued learning among the group. And then it's important to, like I said before, you're in a community, right? So when you go to journal club, you're going to be in a diverse group. So when I present journal club, I have senior gastroenterologists from different subspecialties. Dr. Bang is an interventional gastroenterologist, may have a different clinical experience and expertise than someone else like Dr. Kelly or Dr. Rupawala, who specialize in IBD. And it's really valuable to have all of those different perspectives at a journal club. And as a trainee, I've been doing gastroenterology for less than a year. And it's amazing to have mentors that can teach during journal club and to feel open for sharing. When I talk about a clinical vignette or I apply data, my perspective is going to be different than somebody who is an expert in the field like Dr. Bang. So being in an environment that is open to sharing and open to feedback is really, really critical. So that's why I think this point is particularly important, that the structure of your journal club needs to be diverse. You should have mentors and mentees present for journal club. So when you're presenting, be open. It's okay to make mistakes. Everybody learns when you share ideas. And then, this seems obvious. When you do get assigned an article or you pick an article, give it to people ahead of time. It's always valuable to have people have some context and read before they present. And then finally, use a structured clinical appraisal tool. Be consistent how you approach journal club. A department or a group should have some outlined goals in terms of what should be addressed in a journal club and what's important. So I think having a critical appraisal tool to help you dissect an article is really important. And I'll go over one example. JAMA has a published series that I think is really, really valuable and available to everyone in terms of going through data. All right, so choosing an article. This can be daunting. I remember in medical school and especially in residency, really wanting to do a good job and spending hours thinking about what kind of article I wanted to pick. Or even if I had a clinical question, having to go through all of these articles that seemed so similar and spending a lot of time on it. I think at the end of the day, regardless of the article you choose, being critical in your appraisal and being able to go through in a systematic way, you're going to do a good job. So going through things that you can do to choose an article first, and I highlighted this in bold because I think it's probably the most common reason people pick a journal article, is really grounding it in a clinical question. So you had an experience on the wards within the last month or a couple of weeks ago where you had a clinical question where you maybe really couldn't answer it, or you came across a point where there was conflicting evidence to support one intervention versus another. I think that's a really good reason to start in choosing a journal article. So that's one you can always fall back on. I think too, if you have a personal interest, if you're doing research, pick an article in that specific field. You may learn something new and enhance your own knowledge. And to that end, don't always pick something that is a strength of yours. Challenge yourself, pick a weakness. If in GI, the esophagus remains a Rubik's Cube for me. It's a very complicated organ, something I need to learn more about. Perhaps for my next journal article, I'm going to talk about the esophagus or an intervention on the esophagus for some specific disease to enhance my own knowledge base. And then two, there's always new clinical guidelines that come out every single week, and it's a lot to keep up with it. If there's something that's new, groundbreaking, that is going to change how practice is made, focus on that article. That's a really good reason. Even if you haven't seen a patient for a year on that specific condition, it may be valuable to do that. And then social media is big. We're on social media right now. If there is a medical topic, so for the last year, basically anything having to do with SARS-CoV-2, pick an article on that. I think people will find it interesting and engaging. Landmark studies. So, a lot of times we pick articles that are new, have been published in the last several months or year. If there's a landmark study that's been done in the last 10 years and it was really foundational to how we practice medicine, you can go over that too. Or a controversial topic. Maybe there's an ethical dilemma in medicine and there isn't great data behind it. Well, why don't you evaluate that? Pick that article and you can have a very valuable and fruitful discussion on that topic. So when you do pick an article, it's not all about finding, an article that interests you or any of these topics. You have to consider a few other things too. So the source is really important. And it's always, it's good to talk about where the journal article comes from. So an article in the New England Journal of Medicine is going to be different than an article in a non-peer-reviewed online publication. So it's important to highlight, where is this coming from? What is the journal? What is their impact factor? And for those of you who may not know what an impact factor is, it's a rating for an article based on how often that article gets cited by other articles. And it's really kind of this gross estimate on how well this journal is read. And I don't want to say how popular, but how prominent this is. So New England Journal of Medicine is one example of a journal with a high impact factor. And then we talked about the timing of publication, and it really depends on why you chose the article. So if this article is a landmark study, sure, if it was published 7 years ago, you can present it. But if it's something that's maybe not a landmark study and more relevant to a clinical case you have, choose something that's more relevant in recent history. And then the type of study. I think a case series probably holds less weight than a randomized controlled trial. It's interesting, in the last year with COVID, there have been a lot of case series publications in some of the biggest journals because we're learning about COVID at such a fast rate. Most of the time, though, I would recommend picking a study that is larger, well-designed, something you can go through with robust clinical data. All right, so these are all the different components of Journal Club presentation. I'm not going to read them off the slide. We're going to go through each and every one of these. So the background. Background's great. I think background for me is one of the most interesting parts of a Journal Club, because you're really going to set the tone and frame the mind and clinical question for this specific Journal Club. You're going to really introduce to the group why you think this journal article is important and why it's worth an hour or a half an hour of their time. So let's consider the image below, right? So this is a CT cross-sectional image. This is, I'll give you the clinical vignette, 65-year-old man with history of hypertension and chronic constipation, presenting with 2 to 3 days of left lower quadrant pain, a leukocytosis to 17,000, and then CT imaging evidence of acute uncomplicated diverticulitis. All right, clinical vignette. I'm sure most, if not all of you, have seen a patient that's similar to this. But the question is, do we or do we not give antibiotics? I think that's a really, really fundamental question. And I think up till about this year or last year, the data would suggest that you do give antibiotics. And there are some new articles out that suggest perhaps antibiotics aren't necessary or won't make a difference in patients who have acute uncomplicated diverticulitis. So I think opening a journal club, let's say you're going to present an article on acute uncomplicated diverticulitis, open with that clinical vignette. It really frames the clinical question, and it brings forth kind of the relevance of the journal article throughout your presentation. So this is from a journal club presentation I gave a couple months ago, and I know Dr. Bang, you were part of this as well, had been part of the audience. I talked a little bit about a new risk stratification tool in patients with cirrhosis. So patients with cirrhosis often get very, very sick when they have surgery. They have high mortality, very poor perioperative outcomes. And I didn't have a specific clinical vignette that I presented, but I wanted to introduce this as a subject. So this is just as an example for you. We're not going to get into cirrhosis and surgery, but to give you the idea of the scope of what you can do for background. So I started my presentation by saying, hey, all of you gastroenterologists, we get a phone call very frequently by medicine and surgical teams to help evaluate their patients with cirrhosis. And they often ask us, is it safe or is there risk associated with doing surgery in this patient population? And the answer is, yeah, there is. And here are the reasons why. And I use this slide just to go through some of the basic reasons why patients with cirrhosis may have poor outcomes when they undergo surgery. So I really set the mind for everyone. I said, we get this phone call all the time. This is a really important question, and this is why it's important. And then what I did is I grounded it in saying, these are the current guidelines for how we make recommendations on patients with cirrhosis who get surgery. So this is what we know so far. Now I'm going to show you a study that will challenge this paradigm or enhance this paradigm. So I really set the background for that. So this is just, again, I'm not teaching about cirrhosis and surgery this morning, but to give you an example of what I've used before for setting a journal club background. All right, and then the study introduction. And I think this is really important, and this is something that's pretty consistent in format for all the journal clubs that we've done in our department here, and then for what you can take with you for your own departments. But introducing the study, and it gets in. So we've introduced the background. We said, hey, this is clinically important for X, Y, and Z. Now we're going to tell you what the bones are of this study, how they designed it, and how they answer their questions. So the first one is, what is the study design? Is this a cohort study, or is this a randomized control trial? And if it's randomized, how did they randomize? Did they randomize on patients? Did they randomize on institutions or a cluster randomization? So get into those details. And then who did the study? This is important too, because you could imagine if there were a group that did a study that was going to make profit off of a certain intervention, that there may be some influence on their interpretation of the study, versus academia where somebody may not have any disclosures to make. So it's always important to have in the back of your mind, where was it completed? Was it at one institution, or was it done at 200 institutions all over the world? And that'll be really important for you in how you make your critical appraisal of the paper later on. And then, like I mentioned before, where was the study published? Was this published in an online opinion piece, or was this published in a journal with a high impact factor? And I'll get into some specific points right now. Anybody have any questions? I want to pause for a moment. This next part, I think, is the most important part of the presentation. So I want to pause before I answer any questions people may have. All right, feel free to share. For those of you who are in the afternoon, you can't blame it on having, being sleepy in the morning. So for those of you in the morning, feel free to share as well. And we're going to have a discussion at the end too. So if you do have questions and you don't want to share now, then we can talk about it at the end.
Sorry, Dr. Roussel, I just have a quick question.
Sure.
Does the format of the journal club presentation, or the format of the journal club is it more of a formal thing, or is it, like, as you had mentioned earlier, like discussions at the ward? Because earlier you had asked us as well who's presented at a journal club. So I think most of us, I mean, we don't have, at my university, we don't have like a formal journal club presentation, but we do have something like where we go and clerk a patient and then we present it at a meeting or something. Is that the same thing? And then, or not? I might be misunderstanding.
Yeah, no, I think that's a great question, Anya. So it's all over the spectrum. So journal club can be very informal, where you're on rounds in the morning with a group and you bring forward an article and you go through it quickly in 10 minutes. Most of the time when it's organized as a presentation in a department, there are 30 minutes or 60 minutes set aside for someone to go through and present an article and be very critical of it. And the presentation that I'm going through this morning really lends itself more to that, where within a department you have time set aside, you have a group of people, and you go through with this specific format in dissecting an article, analyzing an article, and then applying it clinically. So that's a great question. But I think, the point I wanted to make before was that the act of going through evidence in a critical fashion is really important. And I think journal club is a more formal way of doing that and a more detailed way of doing that.
Okay, perfect. I follow. Thank you.
Yeah, of course. That's a great question. Thank you, Anya. And I think too, for those of you who may not have it at your institution, I'm happy to share these slides with you. And even if you were to organize with other medical students, with physicians or attendings in your department and start this, I think it's a great thing to start at an institution. It's done a little bit differently at all the institutions that I've practiced at, but I think this format is pretty much the skeleton and applies to all the different places that I've participated in Journal Club. So thank you for the question, Anya. All right, so the PICO method. Please remember this. This is the most important thing. If you take away anything from this presentation, this format is universal and it's really critical, and it's helped me. So I first learned about this when I was a medical student. And the PICO method is a format for you to really introduce a study. And so what does it stand for? So it stands for P, patients, intervention, comparison, and then outcome. So most clinical studies, you can use this specific format and apply. So I want to give you, just breaking it down a little bit more so you can get into detail. So patient population, you can talk about recruitment, how they included patients into a specific sample. The intervention, what are they doing? Are they giving antibiotics? Are they not giving antibiotics? The comparison. So to use the diverticulitis example before, let's say our sample population are adults between 18 and 65 who are admitted or evaluated in the ED with acute uncomplicated diverticulitis. The intervention is antibiotics. The comparison, group 2, may be placebo. And then when they do group 1 versus group 2, how did they randomize these patients? Was it based on institution? Was it based on a patient by patient basis? And then finally, the outcome. The primary outcome may be hospitalization, and maybe a secondary outcome would be mortality or rehospitalization. So we're going to go through a couple examples of PICO, but this is very, very important, and you can apply this specific format for every clinical study that you present in Journal Club. So I want you all to remember it. All right, so getting back to the example I gave before, from the journal club I had done a couple of months ago. So I introduced it as, the background. It was just a retrospective cohort study looking at a new calculator for cirrhosis and surgical outcomes risk. So I defined the patient population. I said, these are all patients, adult patients coming from a specific hospital system in the United States. So the VA system is a large hospital system that takes care of veterans, to give you all background. So I said, of this patient population, we have 128 different hospitals, and this was the timeline. So that was P for inclusion and exclusion criteria. I included that too, but I'm going to keep moving. The intervention was really studying it's called the vocal pen calculator. So that was the intervention. The comparison was to the old calculators that we often now use in doing risk stratification for patients with cirrhosis undergoing surgery. So that's the C. And then the outcome was looking at post-op mortality. They didn't have any secondary outcomes. It was just post-op mortality. So again, PICO. And then here's another article as an example. So this was a study in 2018 that was done looking at patients who are not ICU level of care or who were not critically ill going to the emergency room with sepsis. And what they were looking at is whether or not the patients were doing better getting crystalloids or colloids. So over here, that's normal saline or lactated ringers. So those are two different types of intravenous fluids. So I outlined the clinical questions. So that was the background, what I just told you. It was a prospective, single center, pragmatic, unblinded, multiple crossover clinical trial. That is a mouthful. But this is descriptive. It was done at one place. It was done unblinded, meaning they did not hide what type of fluid they were giving. It was pragmatic in that it did not change the clinical flow of how they were assessing and administering fluids. And it was done in a multiple crossover clinical trial. So they crossed over from month to month. So here's my P, my patient population. This is who they included in the study. This is who they excluded from the study. So again, patient population, inclusion, exclusion criteria. And then finally, I went through how many patients they included and who they were. For the intervention, we talked about this. They're either giving normal saline or they're giving lactated ringers. And this is how they administered those medications based on a crossover type of format, month to month. The comparison was one to another, so I didn't highlight it specifically in this slide, but it's implicit. And then finally, the outcome, they were looking at hospital-free days. And then the secondary outcome, they were looking at AKI, or acute kidney injury and in-hospital death. So again, two very, very different studies that I applied the PICO model to. Anybody have any questions about PICO? I think, again, if you were to take anything away from this presentation, if you take away the PICO format, I think you are off to a wonderful start in giving a journal club presentation. Any questions? All right, great. So moving on to methods and results. So this is really a fun part. I think it's worth spending a lot of time breaking down the format of a specific paper and going through who they included, who they didn't include, because it really allows you later on in the presentation to talk about things that you would do differently for a study or things that they did well. So again, getting back to teaching, we started with framing within a clinical question. Now, when we get into methods and results, you're going to frame it within a statistical concept. Use this as a medium to teach stats. Use it as a medium to teach a concept about interpreting the data and showing people how you use your own brain to get through this evidence and how it applies. We'll talk about the demographics, Universal Table 1. I stole that from one of my colleagues, Dr. Chung. Universal Table 1 is something that we often see in papers, and I'll explain that. And then getting through how to present endpoints. All right, this is Universal Table 1, demographics. About every clinical study you will see should have this, this table. And it's really important. And it's not just a long, long list of different characteristics that patients may have, something to fly over. I think it's really worth pausing when you do your journal club presentation and pointing out, important points. So this goes back to the presentation I was talking about before, the journal club presentation I gave on cirrhosis and surgery. And this was done at the VA hospital. So for those of you who have never heard of or worked at a VA hospital before, again, it serves veterans that have been here in the military. Most of our veterans are white men. So you could imagine that that has a very, very skewed patient population. And when I presented this, I said, here are the demographics. You can see that most of the groups across the patients that were in one cohort versus another had similar rates of smoking. They had similar rates of alcohol use, similar rates of the type of surgery, similar rates of men, and then race. But if you look, 97% of the people in the study are men. And then the majority of them, 63%, are white. So it's important to point that out, because as you start analyzing this later on and say, I'd like to apply this to a patient who may not be a veteran, there may be limited external generalizability. All right, so I think this is just one way to look at demographics and one important point to pull out when you go through the first table. So always spend time going through patient characteristics. Now, getting into my next point, like I said, you want to frame this within statistical teaching. Use this as an opportunity to review a statistical concept. It's good for a couple of reasons. Stats can be tough, particularly if you don't have formal training outside of a medical education. Statistics will show up on your boards. So wherever you get board certified or whatever credentialing you'll have to go through in your future, you will have to cross the bridge of understanding basic statistics and applying it to paper. So it's a really good opportunity to do some self-teaching, but also to bring forward a statistical concept to a group and to talk about it. So again, getting back to the presentation as an example that I gave a couple of months ago, I'm not going to go through what an ROC curve, or receiver operating characteristic curve, is. This is not the point of the discussion this morning, but just to show you the depth of detail I went in to talk about it. Now, the paper that I presented 50% of their data in ROC curves, or calibration curves. So I really wanted the group to have a good understanding of what an ROC curve was, how to interpret it in the way that I was interpreting it, and then how to apply those results. And it's interesting, I mentioned before, Journal Club often has a very diverse background of learners, medical students, senior trainees, attendings, senior attendings, people who have different life experience. And there are some attendings who may be practicing GI for 25 years, who understand data very well, but may be far removed from a statistical concept they learned in their residency or fellowship training. So don't assume that everybody is a statistics expert in the room. It's important to break down the basics, not only for you as the presenter, but also for people in the audience who may not be familiar with this specific statistics. So I'm not going to get into ROC curves, but this is the level. I had used this from a JAMA article on how to interpret ROC curves, comparing A to C and what the curve in the middle meant and how to apply that to the data. And then I went right to the ROC curves. So I, again, started with the statistical concept. I framed the results of the study, and then I was able to use that in helping patients and helping people in the Journal Club interpret the data that this specific paper was presenting. All right, and then finally getting into critical appraisal, strengths and weaknesses. So this is where you can really get creative in breaking down a paper, and why it's important to spend so much time setting up a paper. Like I said before, going through table 1, going through how they included excluded patients into a study. Where was it done? Where was it presented, or where was it published? All of this is going to play an important part in how you critically appraise the study. So we always like to talk about, why studies are good, and then spend the most of the time in Journal Club talking about what we would do differently. And I think that's great. I think it's important as a group, again, to apply your diverse backgrounds. So this is the hierarchy of evidence. This is something that I learned about in medical school, and you may all be familiar with. Not all research is equal. It's a really important point. And what this suggests is that, there's really a hierarchy of evidence that you bring forward. So the gold standard for clinical intervention studies is a randomized controlled trial. So at the top of this pyramid, that is something that, if we have data from a large randomized controlled trial that was done at 50 different institutions over many years and in multiple countries, we may put more weight into that data. The tendency for that data to affect our own clinical decision-making and its application to our own clinical practice may be different than reading an article on a case series on 4 patients from one institution without any statistical analysis. And this is where it gets back. I didn't get that. You can also try spelling it. So that's nice. Siri thought that I was that she was a part of this this meeting. I'm gonna shut Siri off right now. So getting back to the point, Anya, you had asked before about, what is Journal Club? What does it look like? This is the exercise we go through in our mind when we're on rounds, and perhaps, evaluating data and applying it on rounds and applying it to a clinical decision we're making. So if we come to rounds with a randomized control trial and it's new, and maybe we're going to present to the attending that you don't want to give antibiotics for diverticulitis. If it's a randomized control trial, I could be convinced as an attending that it may be worthwhile considering that treatment route. If it were a case series, I may be a little bit more weary in applying that. And then, at the top of this, it's an important point to make that systematic reviews they're important too. The illustrator put this at the top of the pyramid here, and I think in some examples, a systematic review belongs at the top. But something we've always talked about in Journal Club, so a systematic review will take a bunch of different studies, analyze them together, and spit out a forest plot or a summarization of what the data shows. We always talk about in Journal Club that trash in is trash out. So if you have a systematic review that looks at very small cohort studies, just a few at single institutions, and the level of data isn't very strong, well, the conclusion in that systematic review too may not be very strong. So when you read this illustration, be wary of systematic reviews, that they're not always perfect, and you really need to be diligent in evaluating the level of detail and the level of evidence that goes into a systematic review. But again, kind of stepping back, the hierarchy of research is really important in applying the clinical study. So use it in your critique. If you think it's a very well-designed study and it does occur at many institutions with lots of patients over many years, then talk about that in your critical appraisal. And then the structure of the study, how it was designed. What I really like about that study we talked about before with giving normal saline versus lactated ringers, that it was applied in what's called a pragmatic format. So they used that in an ER without changing the clinical flow. It was unblinded, meaning that patients and providers knew what they were getting, but it didn't dramatically change how they practice medicine. Sometimes studies will go forward and propose an intervention, and it will dramatically change how the flow of other care is provided. And I think that can cause some confounding. So it's really important to think about the structure of the study and how it's designed in that regard. External generalizability. We've talked about this a few times. So getting back to the example I gave before of the study in the VA patients. So the patient cohort that is 97% men and 60% identifying as white. Asking yourself, does this apply to my patient? So if I'm at the VA and I'm treating a patient and I have to answer a specific question, sure, I may apply that specific study. But if I'm elsewhere in a different country in practicing in somebody who doesn't fit that demographic, that generalizability may not be great. Similarly, if a study occurs in one country, it may not be generalizable to another country based on exposures, based on prevalence of other illnesses, etc. So I think it's really important that you always address external generalizability. Does this apply to our patient population when evaluating studies? And then clinical relevance, outcomes are going to be presented in many different ways. There's this idea called a surrogate outcome that has really made its way into literature over the last 10 years or so, especially in cancer research. So looking for a surrogate to something that's meaningful clinically. So let me give you an example. So let's say we're giving chemotherapy to somebody and for prostate cancer, and the endpoint, the primary endpoint is PSA. The study shows that this medication is more effective than any other medication in decreasing PSA in this patient population. But the secondary outcome shows that these patients often die at faster rates and their disease progresses earlier. So does this endpoint of PSA really have clinical meaning? Is that something we're really interested in? So be aware, there are a lot of surrogate outcomes in clinical research today. Groups looking for significance and looking for something that can support their new medication or intervention. So not all outcomes are equal. Often the gold standard outcomes for us include mortality, hospital-free survival. Many studies that look at mortality and staying out of the hospital as really important things may not look at quality of life. So that's something else you could bring up. Are these outcomes important? Why are they important to my patients? And if they're not, what are other things that you're looking for? And then confounding and bias, are there external factors that apply here? Now, if you're looking at two different cohorts and there's a difference in smoking, does that indirectly affect the results of the study? Also, too, is there bias? Is there a way that they structure the studies or recruited patients that includes a bias in one group versus another? So important to talk about when you're doing your critical appraisal. And then statistical methodology. This is something that if you don't have a very extensive stats background can be tough sometimes. But if they did stats in a way that you don't agree with, or perhaps wasn't the best test, talk about it. I think it's important to bring up. And then finally, I don't think this is discussed enough in Journal Club, but the ethical applications. You know, I think oftentimes we talk about a journal club, oh, wow, how did they get this study by the IRB? The IRB is a group that reviews research and decides whether or not it's ethical or not, and it can be brought forth. So talk about it. Is this something that you think is meaningful to your patients? And if it's not, does it exclude a specific demographic of patient? Is it biased in any way? So I think it's really important to address ethical applications as well. Just a reference for you all, you may want to write this down. This is something that we teach here at Brown, the internal medicine department, and also I've used many times, is the JAMA User's Guide to the Medical Literature. Has a series of, I think it's about 40 or 50 articles that talk about, you know, different things in stats and how to break down a journal club. So the ROC slide that I showed you before is from that. And I often go to this to really understand a paper, and also too, to understand how to teach a statistical method or idea. So this is a really good resource for you all. And then finally, you know, I think this is one of my favorite parts of Journal Club, is at the end, everybody talks about what they would do differently for an article. And then you could talk about future studies. You know, some great research ideas and research projects have come from presenting a journal article, being in a group of people with different backgrounds and talking about what you would do differently, and then using that as a foundation to design the next study. So take time, always set a few minutes of time to talk about, you know, how would you design the next study? If what you presented was a pilot study, what does the randomized control trial look like? Or if they designed a randomized control trial, if you were to redo it, what would you do differently? And perhaps that's something you could bring forward. And then last but not least, every single presentation should have time for questions and discussion. Without format, just at the end saying, hey, who else has some ideas or anything they'd like to share about this? I think too, this is a great time for you to close the journal club, and you relate it back to that clinical question. So we talked about it, you know, early in this presentation. One of the biggest reasons to choose a journal article is it relates to something that you've seen recently, or perhaps you have an unanswered question on patient care and you want to really be critical about applying that article. So this is the time to go back and say, hey everyone, you remember the patient we talked about, that 65-year-old man, history of hypertension, presenting with uncomplicated diverticulitis? Well, let's go back to that patient and apply this data. And this is the decision that we made, and this is why we made it. So always feel free to go back to that clinical vignette you started with, and then round out the discussion by closing with a clinical vignette. And that's all I have. So I think we are done with the presentation, and I think I would love to start and just answer any questions on Journal Club. And then we can talk a little bit about, you know, my experience in internal medicine and chief year, and hopefully answer some questions for that too. So again, I appreciate everybody's time and attention to this. And this is a picture of Second Beach in Newport. So this is about 30 minutes drive from the capital of Rhode Island. Very, very small. And it's a beautiful area. If any of you come and do an exchange program here and work with us, I'd be happy to take you down to Second Beach and show you this. It's a very beautiful area. So with that, any questions at all?
Thank you so much, Dr. Roussel, for the presentation. I think it's definitely helpful. There are some questions in the chat box. I can just read them to you if that's fine.
Wonderful. Yeah, thank you. I appreciate it, Anya. Okay,
our first question is, when do you use results of an article to change your clinical practice?
Yeah, that's great. That's a great question. And it's the foundation of why we pick up articles and we try to apply it. I would say loosely every day. You know, we're really trying to incorporate more evidence into our decisions. But I think too, if you ever have a question, and the article, and you go looking for answers, and the article has some, you know, it comes from a good place, it's well designed, and it's something that you think would be meaningful to your patient, you can apply it. I think it really varies on the clinical point. You know, some decisions carry more weight than others, right, in medicine. So I would argue that giving one type of intravenous fluid over another may be a small clinical decision you make if you're working in an emergency room in somebody who has an infection. That picking normal saline versus that other one, lactated ringers that I spoke about, may not make a big clinical difference. Now, if you were meeting somebody in your oncology office for the first time and you saw the first article ever on this new intervention, and it was not yet incorporated into guidelines, into, you know, standard clinical care, you may not use that one randomized control trial to make a decision on giving that new medication. So I think it really depends on the clinical question at hand, the gravity of that decision you're making, and then what is the standard of care? Is it very different to the standard of care? What is the level of evidence in an article? So I think there's a lot that plays into it, but those are some of the things that go through my mind when I'm making a decision and applying an article.
Perfect, thank you. And the second question is, what about funding? Do you mention that? And is there any impact on the study?
Great question. Yeah, I didn't mention it specifically, but I alluded to it early on. I talked about, the source, really important as you introduce an article to talk about where it comes from. So is this industry sponsored, meaning did it get funding from a for-profit institution that may be putting forward a medication? So Pfizer is a very, well-known pharmaceutical company right now with the vaccine, but if Pfizer put out a medication like, I think they designed azithromycin, early on in those studies, if it was just Pfizer presenting this, I'd say, hey, everyone, just be aware that Pfizer is the one that's presenting this. They did fund this research versus an academic institution that may be not funded by a specific for-profit institution. So yes.
Thank you, Dr. Roussel. My own personal question is then what would be the first step in getting your group of friends or other colleagues to actually start a journal club? As mentioned, we don't have one of those in my university.
Yeah, great. So I think it can go a few different ways. One is you send an email to some of the colleagues that you enjoy learning with and spending time with, and invite people in your class to get together and talk about an article. So I think that's the first step. Another one too is to go to leadership within your department or within your school and ask for this. Say, I think this would be a valuable educational resource. Can we start this maybe once a month or once every 8 weeks? More formal way, get together for an hour and talk about a journal article. And I'm happy to share these slides with you, Anya, and use that as kind of a building block for a format if you'd be interested, or anyone else on this call as well.
That would be perfect. I think I'm definitely going to try and attempt to do one of those, at least in my vicinity. Thank you, Dr. Roussel.
And what other questions do any of you have?
Hi, Dr. Roussel. I'm Davy from Cameroon. I just want to know, how do you strike the balance between referencing landmark articles or, let's say, journal club presentations versus clinical guidelines, established clinical guidelines in clinical practice? Like, how do you know when to choose the clinical guidelines and when to use the journal club presentation?
Mm-hmm. Yeah, David, very nice to meet you, and thanks for the question. I think it depends. So if you have a recurring journal club, every month, the department or a group of students gets together and presents an article, it's really nice to present a variety of articles. So I think to your point, maybe starting with a paper that are clinical guidelines, and then the next month, talk about a randomized control trial that is completely new and maybe trending in social media. And then the month after, presenting a paper that is relevant to a specific clinical question. And then after that, go back to a landmark study and incorporating variety of sources longitudinally in a department. But also too, I think it's what you find important in the moment. If you have a journal club presentation coming up or you're organizing one and you think it's going to be a rich experience for your colleagues to hear about this, whether it relates to a specific patient or another experience you had, I think it can be in the moment too, into what you find is important.
Okay, thank you.
Great. I appreciate all the questions. Thank you for being engaged during this talk. Dr. Ossenbang had asked me too to talk a little bit about my own experience in training. And I think it's really interesting in that training across the world is different in terms of the steps you go through and the experiences you have to become a physician. And at the end of the day, we're all physicians with different experiences, which I think is very nice. In the United States, we often go through 4 years of undergrad, and then we go into medical school for 4 years. And then for internal medicine, which is the residency before you do GI training or fellowship, it's another 3 years. I chose to extend that year, to extend the 3 years by 1 year and do what's called the chief year. And that year, we are a residency here of about 150 different residents. And then 5 of us we stay on for 1 more year of work, where we do mostly teaching. We serve as an attending on wards, and we essentially run the educational format of the residency. So that could be journal club, that every morning we have meetings and go over cases called morning report. Noon conference, we talk about didactics and different, different types of learning subjects. And then we help format the residency. And I shared that responsibility with 4 other of my co-chief residents who are wonderful, wonderful people, some of whom stayed here at Brown to complete their training. Grateful to all 4 of them. But Dr. Asenbeng, I know you too served as a chief resident after your Meds Peds training. You and I have talked about that before. So it was a very rich year, and now I'm in my first year of fellowship, and GI fellowship can be anywhere from 3 and very rarely 5 years long. So 3 for general GI, and then if you want to do an additional training to do interventional GI, you do an advanced fellowship for 1 to 2 years based on incorporating research into that. And then you can subspecialize too in GI into inflammatory bowel disease, the esophagus, motility, a bunch of very interesting different fields. So I'm in the first year of many more years of training, and it's been a whirlwind of learning, and I've really loved it. But I have a couple more years, fortunately, here in fellowship, and then we'll see what's after that. So, any questions on training here in the U.S. or?
I have a question as they're thinking of questions. I do have a question for you. So the first question is, as a chief, how, what would you consider as some of the, good, excellent traits, in whether it's in the medical students or in your residents as they started, what would you recommend for the students to do to try and become, stronger doctors? And then the second question is, why did you choose GI? I mean, I know it's the absolute best thing anyone can ever choose, but why did you decide on being a gastroenterologist?
I'm having those for our interview, Dr. Asenbeng. All right, so for the first question, this is something I often speak about to the medical students who rotate with us. So when I'm attending on the wards and really getting people incorporated into the group, I always challenge people to envision themselves at a step ahead of where they are in training. And by that, I mean, when you're a medical student on rounds, on the wards, taking care of patients, I really want you to be the patient's doctor. I want you to embrace that role. Rounds, when we get together for rounds, it's a group of people and we talk about the plan for the day. And I encourage our medical students, I want you to independently think about the plan. What would you do for this patient? What is your plan? And rounds and sharing these ideas is a safe place because, when you come forward with your idea, if it's something that's very reasonable and we agree with, great, we're going to go with that. But if you come forward and say, I'd like to give this antibiotic and we think that a different one should be given, everybody in the group learns, including the student. And I think too, it gives students a sense of ownership over their patients to really embrace that role of being a physician. So if you're, we tell our 3rd year medical students, really try to be a 4th year or a sub-I, we call it. If you're a senior medical student, I really want you to envision yourself in the role of being a junior trainee or, a physician, and really embrace that role and share your ideas and think independently. I think the second part to that is inquiry, right? So that doesn't mean you can't ask questions and ask for help. That's always welcome. Always ask questions about, a specific understanding or teaching point. That's fine. But I think those 2 things, taking ownership and envisioning yourself in one role, and then always practicing inquiry, asking, the group about their own input, or even being autonomous and getting an article and asking yourself, are antibiotics indicated for this patient? Going to the literature and bringing that to rounds, I think, is really helpful. So that'd be my advice. And I think that the students that really excel do those things very, very well. And I think it's so much more fun too when you're a trainee and you are in the role of a doctor and you walk into a patient's room and they look at you and they call you their doctor. I think that's such a fulfilling experience. So I encourage all of you students and trainees to really embrace being the patient's physician, being their doctor. Okay. And then GI, why did I go into GI? I feel like that's the only thing people should go into, Dr. Asenbeng. It's such a wonderful field. I think what I love about GI, internal medicine I really liked, and in chief year, I kind of embraced this more, is learning and the different pathophysiology that you can experience. Internal medicine has a breadth of, heart failure. It has autoimmune disorders. It has anatomic issues. There are infectious disease we deal with, malignancy. And if you look at all the fields, all the subspecialties, GI is one of the few that embraces all of those things. So, you know, in a colonoscopy, I can encounter a structural deformity like a stricture. I can encounter inflammatory bowel disease, where somebody has rip-roaring autoimmune disorder. I can see CMV or a really bad infection in that same patient. I can find malignancy and hopefully triage that patient to treatment early in a meaningful way before the cancer spreads. So I think what's beautiful about GI is anything that can go wrong in the body, I promise you that it goes wrong in the GI system, be it the liver, the pancreas, the esophagus, the colon. The breadth of pathophysiology is wonderful. So I didn't want to lose that when I specialized in internal medicine. And I felt like GI allowed me to do that. And I think what's neat about GI too, here in the United States, there are a lot of emphasis on procedures and interventions and things that we can do. And pharma and industry has a very robust research and development program in the United States where, you know, problems come to us and we can treat them with immunologic medications. We can treat it with immunosuppressants, antibiotics, all these medications, but we can also fix things with our hands too. And Dr. Asambang in her role, and I don't mean to speak for you, but you do this every day where you can go and you can relieve suffering by placing a stent or get more meaningful clinical information by doing a very complicated ultrasound with a biopsy. There are things that we can do in GI with our hands that can save lives, can make people feel better, can make a diagnosis. So it's that mixing of using our brain and using our hands that I think really lends itself to this field. So as somebody who loves variety and loves doing both of those things and imparting, you know, care in many different ways, GI is great. So if you all want to become gastroenterologists in the future, I support you. And if you don't want to become a GI doctor, that's totally fine too. There are wonderful ways to serve patients. So
Yeah, I think we have Davey who's on, who's convinced. You know, he's going to be Dave, you want to turn on your camera if you're able to? Davey's going to be a gastroenterologist. We're working on the others, but they've chosen a path that we all support, and we're super proud of them. All right, you guys, you want to ask any other questions? I have to be, we have to be super respectful of Dr. Roussell's time. We're on the hour. Any other questions from anyone before we wrap up? Any questions about Journal Club? Go ahead, Anya.
Sorry, I feel so bad. I just keep on talking so much.
No, please do. You're asking questions that others are thinking.
So Dr. Rizzo, you've already mentioned some things that basically make a student stand out in their respective schools. But what else would you suggest to I guess, enhance an application or make you become one of the more outstanding as well as a standoutish student when you're applying for something that then everyone else is applying for, and you know the competition is the same, if not more, to what you can offer? That's you've mentioned things on the wards, but I mean, for example, as mentioned, we don't have things like this in our countries. I mean, some of us don't, at least, or in our schools. So it becomes a bit difficult to, I mean, implement something or become then like the head of something within these departments, but then you're still competing against other students that have experience in these journal clubs or other fields, other activities.
It's a great question, Anya. And I think that is something on every trainee's mind, is when they go forward and they apply to the next level of training, how does their application look? I think that's a really important question. My advice to you and to everyone on this call is to pick something that you're passionate in and do it very well. Do it very well. Become excellent in that. So by that, I mean, if you are interested in providing healthcare to patients who are less served in your community or in a rural area, really invest yourself in that. Either start something or get involved in something, and really invest yourself in that heavily. So maybe that, if you're part of a group, you're going to then be on the board of the group or get a leadership position or spend a lot of time doing that. And then if you do that, write an opinion piece and submit it to a journal article. If you're going to do something, kind of take it to the next level. And that's in contrast to the applicant who does 10 different things and does them pretty well, but doesn't really invest themselves fully into something. So if you're going to choose something, be it research, be it an outreach program, be it an educational program at your own institution, do it and do it well. And I think you can use Journal Club. So Anya, if you were to choose to bring Journal Club forward at your group, try it out with some of your colleagues. And if it works, then formalize it, give it a name, make sure it's scheduled regularly. You know, give it some kind of title and status at your institution. And then when you go forward and all of you, you apply, you can say, this is the group, this is the, the journal article. It could be either, I don't want to call it journal article interest group. That doesn't sound very interesting. But kind of a more formal name to this process, and say, I started this at our institution. We didn't have this. I brought it here. It's a regular thing now. We have 10 participants and all of them find it meaningful. Really invest yourself in that experience and take it to the next level. So, and I appreciate, every institution has limited, different resources, some more limited, some greater than others. And, play off the strengths of your institution and then your own interests, but take it to the next level. That'd be my advice.
Perfect, thank you. And one last question. In the process of writing personal statements, how do you incorporate all of this information without sounding like here is a piece of paper with just facts about me, but I'm trying not to boast, but I do want to see I do want you to acknowledge my accomplishments. Mm-hmm. So what would your advice be in going about perfecting a personal statement?
Yeah, I think just be sincere. Don't try to have a wow factor in regards to doing something or have showmanship in a personal statement. Be sincere, talk about who you are, what's meaningful to you, and I think it'll write itself in that regard. I find that personal statements and ones that I've reviewed that are someone is really trying to have an opening statement that is controversial or something that really has the reader step back is not something that is helpful. But people who are sincere and have a meaningful experience and want to talk about what makes them, what makes them go as a physician and why they want to help people, I think that personal statement both writes itself and it reads very easily well. I will say personal statements are hard. I've always struggled writing personal statement, not wanting to, talk about myself and go, it doesn't feel great sometimes and it takes a lot of time. But I think once you're true to yourself, it helps write itself. And getting back to the former statement I made, if you invest yourself in an experience and really take it to the next level and do something in an excellent way, you can talk about that in your personal statement. And I think that too will really write itself. So I hope I answered your question. I'm rambling now, Anya, but I hope that was helpful.
No, thank you so much, Dr. Roussel. I'm trying to also just, again, as you had mentioned, think one step ahead. So all of the questions I'm asking as well will definitely, I know, benefit me, and I hope that they benefit my colleagues. But thank you so much.
Yeah, you're welcome. You're welcome. Any other questions?
All right, that was great. That was really, really good. Like I said, truly appreciate your time. I mean, that was great in terms of the Journal Club presentation, and then your words of advice are very much appreciated. And I was actually just texting with someone we were talking about sort of some of the next steps, and one of the things we discussed as an organization was to start having journal clubs and case presentations. Where we would have medical students, present a journal club, and hopefully we can get experts like yourself on some of those sessions with sufficient notice, where the students present, and then the experts like you could comment on the subject matter or their presentation and stuff. So, so this is fantastic. Yeah, thank you so much.
Participate. Thank you, Dr. Right. Thank you, everyone. I appreciate your time.
Thank you so much, Dr. Roussel. Have a great day, everyone. All right. Ending the session.
Thank you.
Dr. Akwi, if you have 2 minutes to spare, can we quickly chat?
Yes, and I'm going to end this meeting right now, and then we can talk for sure. Actually, hold on one second. Yeah, no, it's still live streaming, which is okay. It's not a problem. I just need to figure out. Here we go.